I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, we are discussing Suicide Prevention Awareness Month, and I am interviewing Dr. Ryan Wagoner. Dr. Wagoner is an assistant professor in the Department of Psychiatry and Behavioral Neurosciences at the University of South Florida. He's board certified as a forensic psychiatrist and leads the forensic division at the University of South Florida. He is also the program director of the Forensics Psychiatry Fellowship. Welcome, Dr. Wagoner.
Thank you for having me.
Dr. Wagoner, could you tell us a little bit more about your role as a forensic psychiatrist?
Sure. So many people ask, what is a forensic psychiatrist? They hear it and they immediately get these images of a couple of different things. Sometimes they think of something they may have seen in a movie. Every once in a while, I get asked if I provide therapy to dead people, and neither of those is quite true. A forensic psychiatrist is a subspecialty within psychiatry where we deal with the intersection between psychiatry and the law. You can imagine that many times psychiatric symptoms and issues can lead to interactions with the legal system. And it happens so often that we need to be able to answer questions about this to be able to help both the lay public but also the courts to understand a bit about psychiatry. And so forensic psychiatrists are trained really to be an interpreter, to take complicated medical jargon and then distill that down so that it's understandable both to members of the public, but also judges, lawyers, business people, those sorts of things. So I like to think of the specialty as really being an interpreter of these issues. We work in various realms, including civil law as well as criminal law. On the civil side, you may think of us as experts for things like malpractice cases, personal injury, those sorts of things. On the criminal side, you'd often see us in cases involving competence to stand trial or not guilty by reason of insanity, providing expert opinions. So that's a bit of an overview of what I typically do.
Would you be able to share with us some information about some of your experience with first responders and the trauma that they're exposed to?
I've had a couple different areas to interact with first responders, which gives me a different perspective on multiple areas of working with them. The first was actually, I previously did some ride-alongs with police officers in order to just get to know them and what their job and their role was. And this was actually during my residency training. We did some research with that, did some poster presentations, but I thought it was very valuable just to get to know what do they do on a regular basis, just driving around and what their struggles are. In my practice, I've actually been able to see a number of individuals clinically who are either first responders, they're paramedics, they're police officers. And then finally, in the medical legal context, I've seen a number of individuals for issues like disability or fitness for duty, typically at the time when the person has developed symptoms and it's now actually affecting their job. So I've seen it from multiple different aspects, how the job can actually affect first responders and how psychiatric symptoms can arise from that.
What are some of the ways that first responders could seek treatment for trauma exposure?
It varies between departments, and some departments have very robust ways to obtain treatment. So that might include CIT programs, these crisis intervention teams, having EAP programs or employee access programs that allow for someone to seek out help fairly early on, particularly if there's been a major event. Most places will do debriefings of some sort. So let's say, for example, an officer is shot at. There's often a debriefing just so that they can talk about the incident. Now, sometimes that involves mental health services and sometimes it doesn't, but that's one avenue that they can seek treatment. The other way is that first responders will often seek treatment outside of these EAP programs and things for various reasons. They want to keep it a little bit more private, a bit more confidential, but they can seek treatment in multiple ways. Now, the difficulty, of course, is that they often don't seek treatment for this due to
Hmm.
various reasons.
And that actually leads me to my next question. What is some of the stigma that's associated with post traumatic stress disorder in first responders, and what can be done to challenge this stigma?
So there's a couple of challenges in terms of stigma for first responders. One of the first is this concept that many people struggle with psychiatric conditions, where it's a weakness, it's a failing. There's something wrong with me, that I have psychiatric symptoms. This is something we see very often in the public, but it can be magnified in first responders, where they are expected to maintain a high level of performance, socially, occupationally, and so they may think that it's a weakness or a failing to go and seek help. So that can be a major barrier. Another stigma is this concern that if I report it, it's going to come back negatively on me in some way. If I report that I'm feeling a little bit down or I'm having nightmares because of this event, that they might take my gun, they might take me out of the ambulance, those sorts of things, because their concern is that they're going to lose their livelihood. Maybe I can just muscle through it, and if I do, then I won't have those consequences. Both of those things can be quite difficult to overcome, because that it impairs treatment. It impairs the ability to get that person in and start the treatment process. How can we challenge that, as you asked? It's a good question. And there's no, like many good questions, there's no single answer. I think education is one thing. Acceptance among the community is getting there. We see more and more stories where people are accepting of psychiatric conditions being just like other medical conditions, things that we have to treat. And I think
Mhm.
progressing with that is going to be a major way to challenge that stigma. Another is to just inform people that uh, being supportive and being there for loved ones, during these times when they might go through traumatic events, um, that can be helpful, that education piece. So I don't think that there's one specific thing that can challenge this stigma. I think we're headed in the right direction. We're seeing more and more emphasis on this, of concerns about first responders' mental health and people's mental health in general. But there's still a lot to do.
What could family members or loved ones do to support a first responder who has experienced something traumatic?
It depends on the person. This has got kind of multiple answers to it. The first is, and this can be hard for people, sometimes just listen. Sometimes someone just needs a sympathetic ear to be able to talk about, these are my struggles. We all want to immediately jump in and help that loved one, but sometimes just stop, as I sometimes have to say, stop talking and let the other person talk, and just listen to what their struggles are, and then help them to find the assistance that they might need. So if you, as say your spouse who's a first responder, you notice that that person has become more irritable, more withdrawn, seems unhappy and dissatisfied with everything having to do with their life, you might say, do you need to talk and just listen? And if the person opens up, then maybe see, well, do you need to see somebody professionally who can talk with you about that and help us through it. One thing, though, that I want to make clear that you don't want to do is just wait till there's something traumatic. When we look at first responders and how they actually develop symptoms of major depressive disorder or PTSD, it's actually really not this specific traumatic event a lot of times. There are some who will get involved in a firefight, or they'll actually be shot at, or they'll have somebody die in the ambulance on the way to the hospital. Those do happen, and they can be quite traumatic and lead to symptoms. But what occurs far, far, far more often is that there's this accumulated effect of seeing things day in and day out. When I
Mm.
see, for example, a police officer, it's usually not, hey, I was shot at and that's why I've developed PTSD. It's more, I have responded to car accidents for the past 10 years where I've seen absolutely horrendous things, or I've seen terrible issues with parents abusing children, or something like that. In fact, that's one of the reasons that the DSM-5, which is one of the manuals that we use to diagnose mental disorders, the update to that, which is the DSM-5, included specifically that the repeated exposure to the aversive details of trauma actually qualifies for PTSD. So there's some recognition that this buildup over time can really cause these sorts of symptoms. So I would say, as a family member, one thing is to listen, but the other is don't wait for something traumatic because they're probably experiencing these traumas throughout their career, and you should be vigilant and ready to listen to them, even if there's not something specific you can put your finger on of, oh, this is why you're feeling this way today. Sometimes it's 20 years of being on the job.
Wow. Thank you so much for sharing all of that. That was just amazing information. And I think you touched on something that's very important when it comes to, supporting a loved one through trauma. I think oftentimes people have the intention to listen, but they end up talking because they want to try to help. And I think simply by listening, like you stated, that could be a very powerful component to their recovery. So thank you for sharing that. So, as you know, September is Suicide Prevention Awareness Month. What could you share with us about suicide rates in first responders?
It's a topic that is difficult to sometimes pin down. And I say that because we're looking into it more and more in terms of research. But there are some barriers to that. One is this is not something that hits the news very often. We hear about first responders being involved in dying in the line of duty, somebody's being shot at, there's a fireman that's shot at or killed in the act of duty. But in reality, we don't hear very often about suicides. And there's a notion that it's fairly underreported. There's some estimates that we only hear about 40% of suicides in first responders, and that 60% of them are going unclassified or unreported for various reasons. The actual rate is difficult to really pin that down. We know that overall in the United States, we're talking a suicide rate of about 14 individuals per 100,000, and it's risen to being the 10th leading cause of death in the United States. And I think that that's still somewhat consistent with what we would see with first responders. However, I think an interesting statistic that's come out that's both startling and concerning is that more first responders die by suicide than they do in the line of duty each year. So we
Wow.
automatically think about, say, for example, being a police officer as being a dangerous job. But in reality, the greater danger is not dying because of something that you're doing at the job, but rather that person choosing to take their own life later. That's actually risen to be a higher risk than line of duty deaths.
Wow, that's amazing. Thank you for sharing that with us. Do you know if there has been any research findings on effective prevention methods for suicide in first responders?
I think that there's been constant research that has been looking at how to prevent suicides, how to identify people who are suicidal and then get them appropriate treatment. Oftentimes we try to reduce what we call dynamic risk factors. When we look at risk factors for suicide, you have static ones which are with you they're just with you. There's not things you can change. So, for example, a static risk factor might be previous suicide attempt. That's a risk for future suicide attempts. We can't go back in time. We can't jump in the DeLorean and go back to stop that first attempt. But we can change things like dynamic risk factors. And these are things that are affectable by change. So, for example, substance use. Substance use disorders actually dramatically increase the risk for suicide. And so, getting effective treatments for substance use disorders could reduce the risk for suicide. And that's research across the board. That's not specific to first responders. For first responders, it's slow going and there's not as much out there. One thing that I haven't mentioned that perhaps is important towards this, and we may see more emphasis, is that although the chronic issues with the job and being exposed to trauma can lead to more incidents of psychiatric conditions, another aspect of first responders' job is actually the administrative burden that comes with many of these different roles. So you can imagine that in most of our jobs, we all hate to be asked about turning in the TPS report over and over. I don't even know who even gets that reference to Office Space anymore. But it's true that, you get frustrated and annoyed with the administrator who asks you for the same thing over and over. And the same sorts of struggles occur in first responders. And you can imagine that that's being overlaid with a job where you're going out, you're being exposed to trauma, you're risking your life on a regular basis, and then you're coming home and being told, hey, wait a second, the report you did today was not sufficient. I need you to rewrite it 3 times. Or we didn't like how you did this. And so they perceive some sort of bureaucratic response from their administration. And time and again, I've heard from police officers, paramedics, firefighters, that can be one of the most difficult parts of the job, is actually dealing with that administrative burden in addition to everything else. And so to answer the question of what sort of research findings there are on prevention methods for suicide and first responders, I think one of the areas that needs to be looked at very closely is how can we reduce the administrative burden on them, in addition to some of these other things that we've discussed during this podcast today. Because if we're just forcing them to do things because that's some sort of administrative goal, but it doesn't provide any real benefit, that may be something to reduce stress levels for them and may help specifically with first responders, because it is often a topic that is discussed amongst police officers, firefighters, paramedics, EMTs, about how much of a burden that really is. I hear that both in a clinical sense, and I've heard that personally from friends of mine who work in those particular roles.
That's such a great idea, and thank you for sharing that with us. Thank you for joining us today on the NEI podcast, and we look forward to maybe chatting with you again sometime.
Anytime. Thank you so much.
This podcast was brought to you by NEI Learn. Access all of NEI's CME activities from your mobile device. NEI Learn is available for download on iTunes or Android.